Okay, we're going to go through a variety of diagnoses, clinical conditions in this talk. By the end, you should be able to cite the pertinent clinical information regarding definition, classification, diagnosis, and treatment of intellectual disability, fetal alcohol, Fragile X, autism spectrum disorder, cerebral palsy, myelomeningocele, and attention deficit hyperactivity disorder. So intellectual disability. This is what was formerly known as mental retardation, felt to be obviously a pejorative term, so that term was replaced. With the release of DSM-5, the diagnostic criteria have completely changed. There are now 3 requirements for the diagnosis. You have to have deficits in intellectual functions confirmed by both clinical assessment and individualized standardized intelligence testing. There have to be deficits in adaptive functioning that result in failure to meet developmental socio-cultural standards for personal independence and social responsibilities. Those look at 3 domains. The first is conceptual, so think educational issues there. Second is social, and third are practical issues. And the onset has to be in what's known as the developmental period, and that can just be substituted as under 18 years of age. The criteria are met if one area is significantly affected, one of the 3 areas is significantly affected, and the overall prevalence is 1 to 3%. The classification used to be completely dependent on the IQ score, and it is no longer at all dependent on the IQ score. So big, huge point, both for the review questions today and for the exam, not dependent on the IQ score anymore. 85% of kids with it fall into the mild category. So if they ask a question and you're thinking of intellectual disability, think of that mild group. And the mild kids really, they're pretty indistinguishable from typically developing kids a lot of times. They may not reach attention until later. So again, all about functioning, not the IQ score. This is also important because kids in the mild to moderate category would typically benefit more from academic programs in school, whereas kids in the severe to profound categories would do better with either vocational or life skills training. So it depends on how you're going to teach them. It affects how you're going to teach them eventually. The age at which a delay is found typically predicts the severity later on. So if you start to suspect intellectual disability under a year of age, so a child who has really profoundly delayed language skills, social skills, etc., it's one of the things that's going to be on your differential. That would predict a worse outcome later on. After 2 years of age, if you see signs, it predicts mild intellectual disability. And again, the kids with mild intellectual disability or borderline intelligence may not be identified until they enter school. Comorbidities are important because that's often what the parent is going to come to you complaining of. So these include behavioral disturbances, early signs of psychiatric disorders, early signs of autism spectrum disorder, speech and language delays. Think of stereotypic movement disorder, or substitute that with tics and Tourette's type disorder, seizures, epilepsy, motor coordination problems, and sleep disturbances. Now, obviously, lots of kids have sleep disturbances, so that alone is not a big concern, but it's one of the things that parents may come to you with the early presentation. The cause, the more severe the level of intellectual disability, the more likely it is that a cause will be identified. We're able to identify a specific genetic cause in 40% of kids with severe intellectual disability, but only 5% of cases with mild. Fetal alcohol syndrome is the leading preventable cause. So again, think of those, the leading cause of this and the top 3 causes. Fetal alcohol is the leading preventable cause. Fragile X and Down syndrome are the leading gene-related causes. And there's also a 7 to 9 chance of recurrence in a family in a second child or another child if there's a previous child in the family who has severe intellectual disability from an unidentifiable cause. The evaluation, this is going to be the exact same thing that we'll say for autism, so when we get to that point, we're going to skip that slide. The etiology, again, very difficult to determine most times. You want to do a very good take a careful clinical history, do a 3-generation family history, look for dysmorphic features and hard neurologic signs, do the whole array of genetic testing that you think is appropriate. Obviously now that's a very stepwise progression in what we do, but that could include things like a karyotype, Fragile X testing, microarrays, FISH probes, all kinds of things that are available to us now. If you do see focal findings on neurologic exam, consider getting a brain MRI. and then do targeted studies for metabolic disorders. And that's something where I am, we're closest to Cincinnati Children's Hospital. We actually have a metabolic specialist there, and I always involve her if we have those kind of questions. If you suspect seizures, an EEG, and if there's any risk that there could be elevated lead levels, get that as well. Treatment, the key thing obviously is the child's education program. So we talked about in the last lecture the early intervention, help me grow type program. That's good for you until the day you turn 3. Once you turn 3, up until the time you're 21. And in some states of the country, you can actually stay in school programming all the way up until 26. It's incredibly variable. That's probably where the money is in taking care of these kids. You certainly want to address behavioral problems. They can be incredibly disruptive for families and then ultimately impair the child's ability to function socially, which is really what's going to make or break their independence someday. You want to do everything within your power to foster independence. Thing to think about is as the kids approach 18, you want to help the parents to obtain guardianship and conservatorship. So guardianship gives them the legal ability to make the child's healthcare decisions. Conservatorship gives them the ability to manage the child's financial affairs. And you'll be largely involved in that if you do take care of kids with disabilities in primary care. I wind up filling out paperwork on that about once a month. You want to plan for the transition to adulthood, so that would again be conservatorship, guardianship, and also vocational training, and then figure out too how much support they're going to need, where they're going to live, who's going to kind of watch over them, those sort of things. But I think another key thing is not to forget about the other siblings in the family, because a lot of times what will happen in any family where there's a child with a disability, all of the attention gets poured into that child, and the typically developing kids get forgotten. Kids with mild intellectual disability can be expected to live independently with some supervision and support. They generally read at a 4th to 6th grade level, which is why newspapers are written at a 4th to 6th grade level. They can generally hold down a competitive, semi-skilled job, and they're physically and psychologically capable of parenthood. We have several parents in our practice where it's a long story, but the parent has intellectual disability and now they are a parent themselves. Kids with moderate ID rarely live alone as adults. They'll generally have lower level elementary academic skills like kindergarten level skills. They generally are able to use spoken language to communicate, and they can be taught to do simple jobs, household tasks. And then if a child has severe or profound intellectual disability, they're typically going to require a fair amount of support, live in a supervised setting, whether that be a group home or with the family, and they're typically incapable of managing their own affairs. As far as diagnosis goes, deficits in intellectual function, adaptive functioning, onset during the developmental period, again 18. Comorbidities are generally treatable. 20% of kids with ID also have CP or seizures, and 50% have mood, autism, or self-injurious behaviors. Deficits have to be in the developmental period before 18, and the level is no longer based on the IQ score, but really more on the level of support that person needs to function in the community. Risk factors include growth disturbances. I kind of think of this as a two-way street. A lot of times kids who have intellectual disability also will have other neurologic conditions. Those may affect the child's ability to feed and grow well. So they may be small as a result of that. Conversely, if they're small and you can't feed them well, that doesn't help their developmental outcome ultimately. So we spend a lot of time with our GI colleagues trying to help these kids to maximize their nutrition. Look for dysmorphologies. Obviously, there's a lot of syndromes that place kids at risk for developing intellectual disability. Any perinatal complication, head trauma, or syndromic etiologies, again, very commonly seen. Biomedical causes are more likely to be found in more severely affected individuals, and it affects all spheres of function. What does a snail say when it's riding on a turtle's back? Whee! Cerebral palsy. Cerebral palsy is the definition: it's persistent impaired motor function or posture that's evident at birth or becomes evident during early infancy. Key point is non-progressive and is usually not genetic, although it may be part of a genetic syndrome. If it's not clear that it's not progressive, don't label it CP. This is a hard thing. I mean, I've done this for 22 years. I have a hard time understanding this because if you have kids with CP, they have things like spasticity. That spasticity may go on to progress over time and give them things like contractures. So does that mean that it's a progressive condition? What they're getting at is they want to be sure that you're looking to say there's not new symptoms and those sort of things developing in these kids, but the things that they have, like spasticity, may get worse. So it's a little bit of a confusing issue. The incidence is 2 to 3 per 1,000 live births. It's inversely proportional in preemies with both their gestational age and their birth weight. The lower the gestational age, lower the weight, the higher the risk of CP. And the prevalence is 2 children per 1,000 by early school age. Essentially, anything that can injure the brain prior to birth or after birth is a risk factor. Again, the incidence is inversely proportional to gestational age and birth weight. In spite of that, actually more than half of kids are born at term, and the specific cause is unknown in most cases. Let's see, presentation. In general, you're going to see the things that we typically think of with cerebral palsy. You're going to see gross motor delays because of its effect on muscle groups and motor function. We'll see upper motor neuron lesion findings, so those would be the kids with brisk DTRs. You'll see increase in distal muscle tone, but diminished truncal tone. So a parent might come in and say, this child is really hard to hold. They don't help you hold them. And you think of that child with decreased truncal tone. You may see persistence of the primitive reflexes that we talked about in the last lecture, or you may see delay in acquisition of the protective reflexes, again, we talked about in the last lecture. A parachute response, if you're not familiar, you take the child and you hold them in a prone position away from a surface, and you quickly bring them to that surface, and they should put their hands out. So that's helpful when the child is, say, 11 to 12 months old and they start to walk. You want that child to put their hands out if they start to fall so that they don't hit their heads and hurt themselves. And we typically see that at around 11, or you can see it as early as 9 months. We typically see it at 11 or 12 months in just about everybody. And the presentations are outlined in the book, chapter 39. There's more detail on that. There's 4 subtypes of cerebral palsy. First is spastic or pyramidal, and again, that's what we typically think of as kids with CP. There's a second type that's dyskinetic or extrapyramidal. That's 25% of kids, and there's 2 subtypes within that type. There's a chorioathetotic form and a dystonic form. The third is ataxic. Those are the kids who have kind of writhing motor movements associated with their CP. And then interestingly, we refer most of our kiddos to Cincinnati Children's. They have a big regional referral center for cerebral palsy. And we'll get a lot of kids that come back diagnosed with hypotonic subtype CP. But if you look at the new diagnostic schemes that are out for it, it's not a recognized subtype in most of those. Back to, again, the first type, 65% of kids have the spastic subtype. So this involves an injury to the upper motor neurons. It's characterized by weakness, typically in the trunk, increased muscle tone, typically in the extremities, increased DTRs, clonus, what's called clasp knife tightness. If you're familiar with a crossbow, as you pull back, on the string, eventually it gets easier to pull it back, or not on a crossbow, on a compound bow. Or if like on a pocket knife. If you open a pocket knife, it's hard to open it up initially, but then it kind of pops open at the end. Those kids, if they have flexion at the elbow, you'll have a really hard time getting it open, and then suddenly it'll pop open. That's clasp knife tightness. They'll scissor their legs because of the effects on the gracilis muscles, and they have a tendency towards contractures, and it's all about your motor cortex and where the distribution of the motor fibers are around the motor cortex, but a lot of those kids were preemies. They have bleeds into the germinal matrix, and that's going to primarily injure those central fibers, which are going to give you those findings. In this category, there are 3 subtypes. There's quadriplegia, which involves all 4 limbs. Diplegia does still involve legs and arms, but legs are much more involved than arms. This is the most common form seen overall, commonly seen in former preemies. And then if you see a child with hemiplegia, you have both limbs involved on one side of the body, and you typically see that after a stroke. And that can be either in utero or after delivery. The diagnosis primarily rests on motor findings that emerge over the first year. Again, the child might be floppy, the parent has a hard time holding them, that they may be irritable, poor feeders, all those are red flags. Tone, primitive reflexes, and DTRs are the mainstay of your diagnosis or diagnostic abilities with it. And it's hard to, like in the first 6 months of life, I think it's pretty hard to identify a lot of these kids, because if you see a lot of under 6-month-olds, you can see some quirky tone development in those first 6 months that then sort of levels out and goes on, and that becomes a completely normal 9 to 12-month-old. It doesn't mean that if you see those things, so let's say at the 4-month or the 2-month visit, that you ignore it. I'd make a note of it, I'd look at that child carefully at the next visit, but I don't get too worried about what I see in the first 6 months of life with regards to tone, because it just changes so much with kids. Comorbidities include intellectual disabilities, seen in 50 to 60%, more commonly seen with the spastic forms, least with the athetoid. 10 to 20 have hearing deficits. You can see visual impairment, especially if they have things like strabismus. Seizures in 25 to 40%. Skeletal deformities are very common. The kids with spastic type, subtype CP, really look at those kids carefully for scoliosis. I have 2 kids in my practice that have the most severe CP, literally more than 90-degree curves, and both of them, they're both the ones, when it was identified, the one was 4, the other one was 6. But if you physically looked at them in the room, you wouldn't even suspect it. There was just nothing suspicious. And for a variety of reasons, we filmed them both, and horrible, horrible, horrible scoliosis in those kids. Oral motor dysfunction, again, a motoric function, so that can be involved. And then poor growth as a result of that, nutritional difficulties, and drooling is commonly seen, again, because of oral motor dysfunction. The mainstay of therapy is to improve their functional outcomes, and that's largely looking at keeping them mobile. There's a whole lot of things involved in that. You want to manage spasticity carefully. You want to get them connected with a physiatrist, PM&R doc. Early on, again, we're blessed to have a referral center where they really look at the kids carefully, and they help the parents to determine what orthotics or other type devices would be helpful for them to have at home. You want to foster communication. The children with oral motor dysfunction may be dysarthric, and so it's hard for them to communicate orally. So if they don't appear to be somebody who will eventually be a good language verbal communicator, look at other pathways such as talker devices or software on an iPad. You can use a lot to help them out. Correct visual deficits, specifically strabismus, get them under good seizure control. If you need to, refer to neuro. Educational assistance is very important because many of the kids have intellectual issues, and then basically prevent any secondary comorbidities that you can. As far as management of spasticity goes, we have used botulinum toxin injections to overactive muscle groups for a long time. They're also now starting to inject phenol. So the beautiful thing with this is you can have a child who really has some specific muscle groups involved with spasticity, bring them in, inject them with either botulinum or phenol, increase the flaccidity then of that muscle group, increase their ability to go through full range of motion with their PT, and ultimately prevent contractures with them. And that has largely replaced pretty much everything else on the list. They used to do a lot of these selective dorsal root rhizotomies. If you had an overactive muscle group, you would go basically open up the back and go to that spinal root, stimulate it. If that was the nerve rootlet that was stimulating that muscle group, you'd cut it. They just don't do too much of that at all anymore because it's been replaced with the Botox injections. Baclofen you can either give orally, intrathecally, or with an implantable pump. The problem with baclofen is it makes kids sleepy, so that's not good. Dantrolene and diazepam do the same thing, but again, they make kids sleepy. Physical therapy and positioning devices are critical. Become very good friends with your local physical therapist because they'll be the ones mainly helping out these children. And then orthopedic interventions to do tendon lengthenings and things have not been needed nearly as much lately with the Botox injections. Knock, knock. Nobody. Myelomeningocele. So myelomeningocele, think spina bifida. If you see a question on the exam and they say spina bifida, that would surprise me. I think they would say, if they're going to use the word or the term, the diagnosis, they're going to use myelo. So think of myelomeningocele, not exactly synonymous with spina bifida, but for the purposes of the exam, synonymous. What is it? It results from the failure of fusion of the neural folds during embryologic development, resulting in a defect of bone, meninges, and spinal cord. Clinically, it results in paralysis of the lower extremities, sensory loss, and neurogenic bowel and bladder. And the incidence in the U.S. is 2 to 4 per 10,000 live births. Risk of recurrence is 2 to 4%. So it's protective for women if they take 400 micrograms a day of folic acid, but you have to take it at least several months prior to conception for it to work. If you've already had a child with myelo, then you take 10 times that amount. So it's 4 micrograms for someone who's never had a baby with it, 4 milligrams for someone who has had a baby with it. Both can be protective. There also seems to be an increased incidence in it with women who are on aminopterin and valproic acid. The diagnosis of it, typically it's discovered either with a tri-screen or a quad screen. These are generally done between 16 and 18 weeks gestation. The tri-screen includes an alpha-fetoprotein level, an HCG, and an estriol level, and the quad screen includes an inhibin A level. So you look for abnormalities in those, and that brings up the possibility of the diagnosis. That then generally leads to an ultrasound, or if you didn't do the quad screen, tri-screen, and you do an ultrasound, you'll probably see the protrusion of the sac in the area that's involved on the back of the child. And then the worst case scenario is it's not discovered until birth. I don't know how many of you in here actually attend deliveries. We used to attend deliveries. We've pretty much been kicked out now, thankfully, by the neos, because I think the kids get much better care. In the event that you would ever be in the delivery room, please, please, please make sure that you keep these lesions covered with sterile gauze and also with saline. The last thing you want to do is to let that sac dry out, because a lot of bad things are going to happen if that happens. With myelo, most kids with it have shunts for hydrocephalus. Shunt infections, malfunctions are eventually or potentially life-limiting or life-threatening. Almost all the kids have continence issues. If you think about it, generally speaking, the sacral nerve roots are always involved with myelomeningocele. And so it's the sacral nerve roots that give us control of our sphincters. If a child with it has urosepsis, there's a highly increased risk of morbidity, mortality. What I tell whenever I teach about this, if you ever have a child in your practice who has myelomeningocele and you get a call, or the on-call doc gets a call from the ER, and that child's in for whatever, if they did not do a urine on that child, make sure they do a urine. Back when I used to do developmental pediatrics as a specialty, that's where we actually nearly lost several patients, was somebody would forget to do a urine check on these kids. High pressure bladders commonly result in myelo, and so this can produce hydronephrosis and renal failure. So they suggest that you do bladder and renal ultrasounds at the ages stated, and then also a VCUG and either a CMG or an EMG at the ages stated. So you're familiar with the VCUG, you basically put in radio-labeled fluid into the bladder, and you're looking to see if they reflux that back up. In a CMG, you fill the bladder with water from a catheter, and then there's also another second catheter that's either in the rectum or the vagina, and you're looking to see if there's coordinated release of your flow of urine, coordinated sphincter function. In an EMG, you're actually putting the needle into the sphincter muscle to see if it relaxes appropriately. Somehow that just sounds completely wrong. How could you ever stick a needle into a sphincter and expect that it's going to relax normally? But that is what's done. Very, very commonly in these kids, we see precocious puberty. Basically, anytime there's a significant brain injury in children, you'll see precocious puberty, or there's at least a risk, so you may need to involve your endocrine friends to keep that from progressing too soon. You definitely want to prevent obesity. These children are already going to be mobility impaired, and so you don't want to let them get too big. That's pretty much true across the board with that and a lot of other conditions, especially cerebral palsy. You don't want to underfeed them and undergrow them, but you certainly don't want to let them get too big. And then a key issue is that you need to know the level of their neurosensory deficit, because basically these kids are insensate below that level. So at a thoracic level lesion, that child may actually come in with something like appendicitis and have absolutely no symptoms or no pain complaint. They can break their bones and present with swelling and fever in an extremity, and you don't necessarily think of a fracture in that situation. And then decubiti are a huge issue, because the kids, a lot of these kids are in chairs, and if they're not moving, doing wheelchair push-ups, they're at high risk for decubiti. I have a couple of absolutely terrible stories about that, and I basically, if I ever ask a parent anymore, have you been checking their bottom, and they say yes, I don't trust them, and I look myself. Other neurologic issues, more than 90% have hydrocephalus with or without a Chiari-2. Seizures are seen in 20%. Tethered cords, you could argue, are seen in all of the kids, because the filum terminale is probably kind of mixed up in all that neural tissue that's back there at birth. And then their IQs can be skewed if they, again, have shunt problems, if there's hydrocephalus, if they have shunt malfunctions, infections. And it's another quirky thing with regards to their academic skills. They have deficits typically with mathematics skills and also with their spatial abilities. So those are things like our ability to think of things that are 3D or read a map, stuff like that. The kids have a real problem with that. As far as ambulation goes, a third will ambulate without assistance, a third with assistance, and a third will be in a wheelchair typically. And it's all dependent on the level of the lesion. So if you have a low lumbar lesion, eventually 95% of adolescents and 40% of younger kids can learn to ambulate with assistance. And if you have a high lumbar or thoracic lesion, only 30% will eventually ambulate. If you're familiar with loft strands, those are like the long arm cane poles. They have a metal wrap that goes around the arms and then a hand rest on the pole. And a lot of the kids can learn to walk with those. What is brown and sticky? A stick. Give you a second for that one. That one often doesn't sink in, sorry. Autism spectrum disorders, this changed completely with the advent of DSM-5. There used to be 5 diagnoses under the umbrella category. Basically, the diagnosis of ASD now encompasses autism, Asperger's, and PDD-NOS. The other 2 diagnoses that were in the category used to be Rett syndrome, which we have several girls in our practice. I'm really blessed. I'm in a practice with 19 practitioners, 20,000 plus patients, and a whole bunch of kiddos with developmental disabilities, and I love to see them. But I also then have the ability to step out and go see a typically developing 3-year-old. So I like being in general peds a lot, but I really do love getting to see my developmental kids. So we do have several girls in our practice with Rett's. I have once in 22 years seen child disintegrative disorder, so we're not going to talk about it. Okay, the new diagnostic criteria for ASDs. The first big category, and this is where I apologize for reading, but there's really no way around it. First category of symptoms are you have to have persistent deficits in social communication and social interaction across multiple contexts, currently or remotely, manifested by deficits in social emotional reciprocity. It's like the kids they don't get the normal social give and take that we engage in when we're interacting. They don't get verbal and nonverbal cues. Next thing related to that, they have deficits in nonverbal communication behaviors used for social interaction, deficits in developing, maintaining, and understanding relationships, and there's a new push in DSM to identify the severity level, and that's largely based on their social communication impairments and their restricted repetitive patterns of behavior. The severity level determination is so complicated, you literally have to have the DSM-5 in front of you and really pick through it with the family to identify what that is, so I wouldn't worry about that at all for the purposes of the exam. But out in the real world, that's one of the new things they want us doing. Second category of symptoms, they need to have restricted repetitive patterns of behavior, interests, or activities as manifested by at least 2 of the following, currently or remotely. So I'll have stereotyped or repetitive motor movements or speech. I had 2 kids in the office. We have 2 families in our practice where there's 3 kids in the family with autism. So as we'll talk about in a second, that's very rare. It's not uncommon to have 2 in a family, but to have 3 in a family. And in both families, it's all 3 kids in the family. It's actually very rare. So the one boy that was in the office just literally yesterday, he'll come in the room and it's not an athetoid movement, but he'll move his arms kind of in an almost athetoid movement, and then he'll just stand and shake real hard when he's stressed, and he pretty much gets stressed every time I come into a room. I feel sorry for him when he has to see me. The kids can also have an insistence on sameness and flexible adherence to routines, a ritualized pattern of verbal or nonverbal behavior. They're just very, very, very stuck in their ways, commonly. You'll have a highly restricted fixated interest that's abnormal in its intensity or focus. I used to say you could diagnose the kids with Asperger's if you had a mother tell you, I swear, back in that time, I swear I wake up in the morning and I promise myself I'm not talking about Sonic the Hedgehog at all today. And within 5 minutes, you're spending the rest of the day talking about Sonic the Hedgehog with that kid because that's all they want to talk about. That's highly suggestive. And then they can either have hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. So if you're familiar, the kids who can't stand the tags in the back of their clothes, or the kid who can't wear long pants, they have to wear shorts in the middle of January in Cleveland when it's 15 degrees, or the kid who has to wear jeans in the middle of August when it's 95 degrees, there's all of those sort of things. And the other big one is their response to pain. A lot of these kids have a very high pain tolerance, so very low responders to pain. So if the kid comes in and you think, maybe they fractured an ankle, but the exam's not really suggestive, I still typically get a lot more films on these kids because they just so under-respond to painful stimuli. C, the symptoms must be present in the early developmental period, again under 18. Symptoms must cause clinically significant impairment in social, occupational, or other important areas of functioning. And basically the disturbances must not be better explained by another diagnosis. Currently, right now, most kids are diagnosed at 3 years of age or older, which is a shame because there's a whole lot you can do for them at an earlier age. But generally, what's going to happen is speech therapy. So hopefully, even if they don't get diagnosed until later, they've been put into speech therapy early on. Many of the kids will have social skill deficits and lack of pre-verbal gestures, so proto-declarative, proto-imperative pointing before 18 months of age. We'll get to red flags in a minute, but there's a study that suggests that if you identify red flags, we can pick out 50% of these kids by 14 months of age, so they reach identification and get therapy much earlier. And again, the AAP new guidelines want you to assess for it specifically at 18 and 24 months of age. Red flags are their social and language development, and is the social and language development of this child comparable to their gross and fine motor development, their self-care skills, and their cognitive skills. So if everything else, the social and emotional skills are very delayed, nothing else is delayed, autism is the likely diagnosis. If everything is delayed, but the social and emotional language usage skills are very delayed compared to minimally delayed for everything else, the diagnosis is still most likely autism. They look a lot at things called joint attention skills, so gaze monitoring. If let's say I'm playing with a 9-month-old and I suddenly look away at something to pay attention to it, the typical 9-month-old will also look away to see what it is that I'm looking at. They get it. Again, there's that whole idea that they get what you get what they get. We're all together in this. If I look at something, they'll turn and they'll look at it. That's called gaze monitoring. You typically see that between 8 and 10 months. If I point at something and I say, look at the light, then they'll look up at it. So that's follow a point. And then proto-imperative pointing again, hey, I want that thing over there. It's imperative that I have it. Proto-declarative pointing, that was really interesting. I do declare that it would be great if you paid attention to that with me and shared in my enjoyment. That's proto-declarative pointing. We see those at 12 to 14 and 14 to 16 months. Next, does the child recognize his name and respond to the speaker? That should happen by 9 months at least. And does the child have simple imaginary play? That should happen by 18 months. The incidence prevalence, as of June of 2016, it was felt that the prevalence was 1 in 68 children in America. There's a whole bunch of theories on that. I'm not even going to touch it because there's just too much to go through and it's not really important for the purposes of the exam. The male to female ratio is 4.5 to 1, so much more commonly seen in males. And it's felt to be a strongly genetic condition with all of these genes listed as potential candidate genes. I think it's important, especially if I were going to pay attention to anything, I would pay a lot of attention to the 22q11 syndrome. For whatever reason, they love that on the exam, velocardiofacial syndrome. And let's see, medical evaluation, review what we just talked about earlier with regards to intellectual disability. It's the same. Treatment, genetic counseling is important. You'll see a 3 to 6% recurrence risk if one child in the family has it and other kids in the family. So again, these two families where they have 3 kids in the family, all with it, very unusual. Parent counseling and education is critical. An educational plan, again, an IEP, the 3-year-old to 21 or 26-year-old plan, incredibly important for these kids. Behavioral management and counseling, important. Therapy for whatever their area of deficit is. Typically, it's going to be language, but it also could be things like occupational therapy involved, either to help them with their daily hygiene, their self-help skills, or if they have sensory concerns, sensory integration type concerns, then occupational therapists can be largely helpful. And we'll just simply leave it with pharmacologic therapy as a good adjunct, but it's not really a treatment per se. We do use a lot of medications in the kids, but there's not a whole lot about that I think they would put on the exam. Rett syndrome, the key thing, if you want to read this slide before the exam, hallelujah. But the thing I would know about Rett syndrome is if they give you a girl who has developmental regression and she has hand-wringing stereotypies specifically, she spends a lot of time just messing with their hands, what they're going for is Rett syndrome. I think they would definitely hit those two things in a question on Rett's. Okay, what do you call a boomerang that doesn't come back? A stick, of course. ADHD classification, DSM-5 again breaks it down into 2 primary categories, the kids that are predominantly inattentive or the kids that are predominantly hyperactive impulsive. There's also, of course, the combined subtype. There's 9 symptoms in both the inattentive category and in the hyperactive impulsive category. You have to have 6 out of the 9 symptoms present in either category to make that diagnosis, unless you're over 17 years old and then you only need 5. That's a new one with regards to DSM-5. If you have 6 symptoms present in both subtypes, you have the combined subtype. Let's see, this is kind of like the autism diagnosis. They now want us to specify if it's in partial remission or they want us to state the level of severity. I wouldn't worry about that at all for the purposes of the exam. The ADHD, okay, the combined subtype is the most common, studied, and well understood form, much more commonly seen in males. An attentive subtype is the second most common. The male to female ratio is nearly equal. Generally not diagnosed until later because the kids aren't disruptive in the classroom, and so they don't reach attention until later. And the hyperactive impulsive subtype is actually very rare because it's pretty uncommon to have a child who's merely hyperactive impulsive without some attentional issues. No one single test should be considered diagnostic. We refer all of our patients to our local friendly psychologist because there's so many comorbidities seen in these kids that I first want to make sure that we get the accurate ADHD diagnosis, but I also want to make sure that we look at all the comorbidities. And then to meet criteria, the symptoms must have been present for at least 6 months to a degree that's inconsistent with the child's developmental level. It must negatively impact directly their social and academic occupational functioning. If they're over 17, they only need 5 symptoms in a category to make the diagnosis, and some symptoms have to have been present since before 12 months of age. Okay, diagnosis. Symptoms must be present in at least 2 settings, typically home and school. There must be clear evidence of an impairment in social, academic, occupational functioning. Symptoms must not be better accounted for by another diagnosis, and if they have a positive response to a stimulant, that's not diagnostic because we would honestly all do better on a stimulant. Scary to think about. Heredity, if you have one child with it, other SIBs in the family are 5 to 7 more times likely to have it. If one parent has it, the risk for the children's over 50%, and there's 3 implicated genes, the D2 and D4 dopamine receptor genes and the DAT1 dopamine transporter gene. And essentially anything that can cause a change in structure or function to the brain increases risk. Treatment, the first-line treatments, typically they suggest that we go with the methylphenidate, but the first-line treatments are the stimulants, methylphenidate or dextroamphetamine salts. The next 5 things all basically describe different medications that are out there. There's short-acting forms and long-acting forms. We generally go for a once-a-day long-acting form, but what I usually do in the office is kind of pin down for the family, when's the child going to take the medication? How long into the day does it last? Okay, now let's pick a specific medication that lasts that long. And that's how I generally decide it. So you're generally looking at a long-acting medication preparation, not short. And most of them have bimodal oral release. So I'm not supposed to talk about brand names in here, but there's some that have some immediate release effect with them, and then there's peaks later on. So if they have specific hard topics in school that you want to target it that way, you can look at the release patterns and do that. The next 3 things, I'll describe 3 of the preparations that are out there now that are a little bit new and novel, different than a straight methylphenidate dextroamphetamine prep, but again, not to go through the brand names. Non-stimulants, specifically atomoxetine, has an indication for first-line treatment, and there are also other medications, including the SSRIs and alpha-2 adrenergic medications like clonidine and guanfacine, which have been reformulated into long-acting preparations that have an indication. I usually actually still go back and use generic, cheap clonidine, guanfacine if I'm going to use those and not use the new ones. The receptors that they act on are what's listed. The stimulants probably mostly act on dopamine, norepinephrine, and serotonin transporters, but it's primarily dopamine where they have their effect. Methylphenidate specifically blocks the dopamine transporter and increases dopamine release. Amphetamines have a greater effect on stored dopamine release. Atomoxetine, we don't really know exactly how it works, but we think it blocks reabsorption of norepinephrine. And then the neurotransmitters, dopamine, norepinephrine, and serotonin are all involved and are all being studied. As far as evaluation prior to putting somebody on medication, essentially what you want to do is a good physical exam and get a good history. Does this child have anything in their past that would make you suggest or suspect that they could have a cardiac problem? And is there anybody, and more typically, specifically, like an arrhythmia problem in the family that had problems early in life? If they do, you do an EKG. If they don't, you don't. The AAP does not recommend routine EKGs on everybody prior to starting stimulants. And knock, knock. Cows say who? No, silly, cows say moo. All right, A better one yesterday. What do you call a bear with no gums? Or what do you call a bear with no teeth? There we go, a gummy bear. A kid told me that one yesterday, and I thought I had to put that in the talk for this year. Okay, fetal alcohol. This is so complicated now. I pray for you that they do not ask you a fetal alcohol question because it's just almost too much to understand. There's 5 categories, 5 diagnoses under this umbrella term now. Fetal alcohol syndrome with confirmed alcohol exposure, fetal alcohol syndrome without confirmed exposure, partial fetal alcohol syndrome with confirmed exposure, and then 2 other related disorders, alcohol-related birth defects and alcohol-related neurodevelopmental disorder. I don't know how anybody keeps this one straight. So basically, the effects are most likely in a mother who had low-level drinking through the first trimester of pregnancy, or if she binge drank frequently throughout the first trimester. Prevalence is approximately 1 in 100 live births, which scares me a whole bunch because that's a whole lot of kiddos out there. Okay, fetal alcohol syndrome with and without confirmed exposure, that's the differentiating thing, but the things that you have to have. For with, you have to have a confirmed exposure. B, you have to have evidence of characteristic facial anomalies, which are things like short palpebral fissures. Think of like narrow eyes, a thin upper lip, and flattened philtrum midface. The lip thing's easy to figure out. The 2 little ridges between your lip and your nose are flat or flatter. In these kids, I think midface hypoplasia is hard to diagnose really in anybody unless you're a geneticist and you've seen a lot of it. It's kind of like, when your Aunt Martha, what's her name? And I can't think of it. it's Aunt Martha. Met her last month. Third, you have to have evidence of growth retardation. To me, this is key. If I have a kid who I am pouring calories into this poorly growing child and they're not growing, CP is one of the things I think of, but alcohol exposure is another thing I really do think of because you can pour a whole lot of calories in these kids and they just do not grow, and they tend to be small at birth. The last part of this is they have to have evidence of CNS neurodevelopmental abnormalities, so they'll have a smaller brain size and therefore cranial size at birth. If you do scanning, you'll see structural brain abnormalities. Basically, these kids don't make gyri and sulci. So you'll have microcephaly, agenesis of the corpus callosum, cerebellar hypoplasia, and lissencephaly, the kind of the smoother brain. And then there can be hard and soft neurologic signs like hearing loss, fine motor coordination problems, difficulty with gait, and eye-hand coordination difficulties. Partial fetal alcohol syndrome, you again have confirmed exposure, then you have, going back into the last categories, some components of B, the facial anomalies, and you have to have either C or D or E. What is E? E is evidence of a complex pattern of behavioral or cognitive abnormalities. So language impairments, later appearance of language or learning problems, poor impulse control, social perception problems, poor capacity for abstract thought, and specific deficits in math, memory, attention, and judgment. Again, very complicated. One of the key things that this points out, though, these kids are at huge risk for victimization because they do not learn from their mistakes. There's a really interesting chicken experiment that they did where they exposed chickens prenatally to alcohol, and basically they just did not learn from repetitive, mistaken type behavior. It's a really kind of a fun study to read the way they did it. Alcohol-related birth defects, essentially you can have effects on cardiac, skeletal, renal, ocular, and auditory tissues. I'm not going to read these to you. And then ARND, you have confirmed alcohol exposure and either evidence of the symptoms seen in categories D and E or both. And ARND and ARBD may exist separately or coexist. Is anybody confused? Yes. So again, my prayers to you that they do not ask a question about it because it's complicated. If you do look at the kids later, you'll see more of the facial, especially facial characteristics, dysmorphic characteristics as the kids get older. Head and general growth, again, are affected. You can see dysmorphic features in the heart, joints, and face, and neurobehavioral problems become primary as the kids get older. They're at huge risk for victimization. Why do cows wear bells? Because their horns don't work. Fragile X syndrome. Fragile X syndrome involves the FMR1 gene, which is carried on the X chromosome. In that gene, there's a series of CGG trinucleotide repeats. If you have over 200, you likely will have Fragile X syndrome. If you have between 60 and 200 repeats, you have the premutation. So typically those are women that are referred to as premutation carriers. Involved males tend to be more severely affected because they don't have another X chromosome to back themselves up, so their IQs tend to run in the 50 to 70 range. Females with it may actually have borderline normal intelligence. It's the most heritable cause of intellectual disability, and premutation females may also have problems with early menopause and fertility changes. We have an incredibly interesting family in our practice where all 3 of the kids in the family have Fragile X. The mom's sisters are in menopause at the age of 35, were infertile throughout their lives, and there's other issues that come up, we'll talk about that in a second, that we've seen in other members of their family as well. What are the typical physical features? They have large ears, soft skin, low muscle tone, flexible joints, long faces, kind of a long, narrow face. After puberty, they develop larger testicles, and you can see seizures in 20%. Behaviorally, lots of things: speech and language delays, delayed crawling, walking, toileting, tactile defensiveness. Again, the kids have problems with feelings of things on their skin. They may not like the feel of a certain type of clothing or lengths of sleeves, pants, etc. You can see ADHD, autism, cognitive impairments, and also commonly seen in the face of intellectual disability, learning disabilities, or autism spectrum disorders in the family. And then again, in this family I was mentioning, the grandpa has early onset ataxia. Summary: involves the FMR1 gene, most common heritable cause of intellectual disabilities. Male and females with it are fertile. The premutation carriers have challenges to fertility. Autism is commonly seen. Seizures can be seen in 20%. You see lots of connective tissue issues with it. Learning disabilities, there's a lot of information in here. I'm not going to touch this because the diagnosis of these actually vary from state to state, and so it's really hard to write questions on it, and I don't think they would do it. If they're going to hit anything on it, they're probably going to want you to know that reading, like language-based learning disabilities, are the most common form. Most kids with it have either average to above average intelligence, and the times where we identify it are at 3rd grade. Kind of think of the first couple of years of your life, you're learning to read. 3rd or 4th grade, you're reading to learn. So we see a lot of a lot of academic problems crop up in 3rd and 4th grade, because if the kids can't read well by that time, they'll get identified. And then you need to be able to think in it with abstract thought going into middle school. So a lot of the kids will present in middle school. And what do you call a pig that knows karate? A pork chop. Okay, and essentially you need 2 standard deviations difference between an IQ score and a performance test, so like the Kaufman, to make the diagnosis. Dyslexia generally presents in the early school-age kids. They present with some problem with language usage. It's a disorder of language that has multifactorial etiology, including genetic and environmental factors. It is not a visual disorder. This is a big thing that the AAP harps on. So a lot of the different kind of visual therapies that people want to do, they're probably not helpful, and they're also not necessary. Reading aloud to a child who's dyslexic is a great way to promote their language development, and there's all kinds of ways you can teach these kids. They typically can actually do very well in school now, because with the advent of so many new teaching technologies, things have gotten a lot better for them. And again, vision therapy is not recommended. I used to start off all these talks with a picture of my 5 kids. Now my oldest son is balding, and he's a 3rd-year medical student at U of L, Louisville. That's him on the left. That's my next, now finally gainfully employed kid. He's a actuary with Mercer down in Louisville, up on top of a mountain in Goblin Valley, Utah, one of our most happy places, and this is them in their happy place, air guitaring on top of this rock. And the point of this slide is study hard, work hard, get through this doggone thing, go to your happy place. All right, review questions. Sorry. I still have 4.5 minutes. We can get through this. Okay, diagnosis of intellectual disability requires 1, an IQ score that is more than 2 standard deviations below the mean for age. 2, poor performance in daily adaptive behavior. 3, symptoms must develop during the developmental period. And your possible answers are A, all of the above, B, 1 and 2, C, 2 and 3, D, none of the above. Okay, and the correct answer is C, because the IQ score no longer matters, remember? It's not how you make the diagnosis. Question 2, true statements regarding cerebral palsy include: the etiology is known in most cases, the dyskinetic subtype is most common, most involved children do not have intellectual disability, the condition is often progressive, and your possible answers are A, all of the above, B, 1 and 2, C, 1 and 3, D, none of the above. Perfect. Okay, the answer is D. In the case of CP, the etiology is unknown in most cases. Spastic diplegic subtypes most common. 50 to 60% of kids have intellectual disability, and the condition must be non-progressive. Question 3, true statements regarding myelomeningocele include: urosepsis is a common complication. 2, a majority of patients have a Chiari-2 malformation. 3, the condition is suggested by an elevated prenatal AFP level. 4, folic acid has been shown to be protective. A, all of the above. B, 1 and 2. C, 1 and 3. D, none of the above. And the answer is A, all of the above. Okay, question 4. Autism spectrum disorder language development is disproportionately impaired compared to gross motor, fine motor, and cognitive milestones. True or false? Oh, okay. Thought we were actually going to get it. Okay, answer is A. And last question, 5. The following is not a criterion for making the diagnosis of ADHD combined type. A, condition present in more than 3 settings. Symptom onset before 12 years of age. C, symptoms present for more than 6 months. D, condition results in functional impairment. And E, requires at least 6 symptoms in each set of inattention and hyperactivity and impulsivity groupings if under 17 years of age, which is not a criteria. And that is right, A. So the others are true. It has to be in present more than 2 settings for A, okay? I literally have 59 seconds left. If you'll let me, I'll tell you my favorite developmental joke. 2 boys are in the hospital, both of them 4 years old, weird hospital, parents don't get to stay in the room, even weirder hospital, 2 kids in the same room, both wake up crying in the middle of the night. The one child says to the other child, hey buddy, what's wrong? And he goes, oh man, I gotta have a tonsillectomy tomorrow. And he goes, that's no big deal. He goes, had that done a couple years ago, no big deal. Just act like it really hurts and they'll give you a bunch of ice cream. He goes, really? And he goes, yeah, no problem at all. And he says, what are you in for? And he goes, I gotta have a circumcision tomorrow. And the kid goes, woof. He goes, really? Is it terrible? And he goes, man, they did that to me when I was born. I couldn't walk for a year.